Okay, why don't we get started here? I know that everyone's taken time out of their busy day to be here. So with that, thank you very much for joining us. My name is Christy Corrente, and I am the Director of Advocacy and Communications for the Canadian Association of Physician Assistants. CAPA is the national voice that advocates for and represents PAs all across Canada. And we also work to introduce and expand the PA profession in all jurisdictions. And with that, we've seen tremendous success this past year alone. 2023 started with PAs practicing in 5 provinces: Alberta, Manitoba, Ontario, New Brunswick, and Nova Scotia. And since then, we've had commitments from the remaining 5 provinces to introduce PAs in one form or another. So BC is going to start small with introducing PAs in emergency departments. Saskatchewan and Prince Edward Island have changed legislation and regulation for PAs to practice there, as well as Quebec and Newfoundland are implementing pilot projects. But it didn't stop there. The success has been wonderful with the demand for PAs. It also requires new PA programs to develop, and I see we do have some of the programs online, so thank you. University of Calgary developing a Master's of PA program, University of Saskatchewan, as well as Dalhousie, whose program is starting in January, actually. Now for the reason why we're all here. Most jurisdictions compensate or will compensate through the health authority. However, we've identified a need for a fair and sustainable compensation model, particularly in a fee-for-service environment. So we commissioned the Conference Board of Canada to explore a model that would allow a physician to bill for the work done by a PA, to bill for that work at a discounted rate. With that, I'm going to introduce our lead researcher, Health Associate Chris Viel, and he's going to walk us through the results of the report. So Chris, I'll let you take it away.
Thank you, Christy. Can everybody hear me okay? Good. Awesome. All right, so it's an absolute pleasure to present to you guys today. We've been able to disseminate this research for the last month or so now, and we're super excited to keep sharing the results and get the word out there. When we had this opportunity given to us about a year ago, we knew that it would be a tremendous impact, and it's been fantastic dealing with everybody and stakeholders, PAs, and various people that are in the field of physician assistants. So it's going to be my pleasure to present the results from our report, Unlocking Potential, Exploring Physician Assistant Funding Models and Impact Potential for 3 Practice Settings to you today. So for starters, I'm just going to introduce myself. So I'm sure many of you do not know me. So my name is Chris Viel, and I'm a research associate in the health knowledge area of the Conference Board of Canada. I have a background in clinical and applied research from mental health, workplace and workforce injury and disability, seniors healthcare, Indigenous health. And in the last 3 years or so, I've taken a tremendous interest and had some fantastic mentors in the field of health policy, health outcomes, and outcomes research, which has really driven to and kind of directed me towards the position I'm in currently with the Conference Board. So before we get started, there's a number of people we need to mention for both funding and support of this project. It couldn't have been done without their, like I said, their support, and I feel like we need to acknowledge each and every one of them. First and foremost is the funder for this. So the Canadian Association of Physician Assistants. We work closely with Christy and Patrick throughout the duration of this project. And I know they had many iterations of the report that they had to go through. So I really appreciate both their assistance and support throughout this. They would also like to acknowledge a funding contributor for this project, which is the Alberta Medical Association. In addition to that, I need to thank both my co-authors for this project. So Micah DeVries, which is another research associate at the Conference Board, as well as the Director of Health, and the other co-author, which is Chad Lever. Again, thank you. Very thankful for their support throughout the entirety of this project. At that point, I'd also like to note that I have no conflicts of interest to declare at this time. The last group of people I'd really like to say a massive thanks to is the Research Advisory Board. So for those of you with experience with research advisory boards, you know that it's a very foundational component to research, especially in something such as the physician assistant field, where there isn't a lot of data available currently. And this is something we'll discuss a little bit more later on. But I'd like to thank Owen Adams, Kristen Burrows, Dr. Jim Wright, Dr. Neil Gibson, David Coons, Dr. Tommy Kirschman, and Sahan and Safi for all playing a really crucial role in each step of this project, especially in identifying crucial data points to build out our model. Next part I'd really like to kind of explain is the Conference Board of Canada. So for those of you not familiar with the Conference Board, we're the foremost independent applied research organization in Canada. Our goal is to deliver unique insights to Canada's toughest problems, and we have knowledge areas across a wide variety of topics, including immigration, health, economics, Indigenous and Northern communities, human resources and leadership, education and skills, sustainability, inclusion, and innovation. So I invite all of you guys after this presentation to visit our website. We have a tremendous amount of research outputs on a variety of topics that might be of interest to you. And it's also the location of the Unlocking Potential report that I'll be highlighting in this presentation today. Now for the fun parts, we get to go over a little bit of the presentation outline for today. So first and foremost, I want to kind of set the stage a little bit and give you a little bit of a project rationale on what brought us here today. After that, we're going to do a little bit of a pulse check on the overview of physician assistants in Canada. So give you some update from our previous reports from the Conference Board. We're going to look at physician assistant impact potential across our medical system. And then we're going to get into the meat and potatoes of this, which is really that physician assistant funding model, where we'll review the model characteristics, some implementation across practice settings. We focused on three, so primary care, emergency medicine, and orthopedic surgery. And we're going to discuss model impact and then end it all off with an overall discussion on how we can really utilize these results to take a step forward. So let's start here. So looking at the project context, where did we come from with this? So if we look back to June 2016, the Conference Board of Canada published the report, The Value of Physician Assistants. So our goal here was to really outline an understanding of a role of the physician assistants within healthcare systems on a broad base, okay? We then took the next step and looked at this gaining efficiency report, where we actually looked at the PA role within the Canadian context. Our next step was to really look at that funding model piece, okay? So we outlined all of the funding models outlined for physician assistants on an international and a national basis. And then we wrapped this all up with an October 2017 report, where we looked at the value of physician assistants, where we made our recommendations for actions moving forward. And what we found when we reviewed this in 2018 or in 2023 was that we noticed that many of the same issues that PAs were facing regarding further integration into Canadian medical systems were the same in 2023 as we saw in 2017. And this really brought us to our overall objective to this project, which is to provide insight into optimal utilization of physician assistants to enhance their presence across Canada's healthcare systems, while also optimizing those system costs. All right, so let's kick things off here. I know this slide, I think this slide is self-explanatory. And if you guys have been listening to the news, if you guys have been on the internet, or even if you look at the lower left there, been exposed to academic journals, we've seen across the country that healthcare in Canada is currently in a crisis. Now, if we look at, there's a variety of factors that are causing this. We've had nationwide staffing shortages. These have sparked longer wait times. We've had a lack of access to primary care for Canadians, had emergency room closures, and we've also had overloaded inpatient care units. If we add to this the challenges that the pandemic has created, we basically end up in the system that we are in currently. Now, I didn't bring you guys here or hope to kind of attend this webinar today to give you a glass half empty perspective on things. So I think really how I'd like to frame this now is that I think that there is a silver lining to this. And as we take a step forward, I think the main goal of this presentation, some of the goal of this work, is that PAs could offer a very sustainable and potential solution to some of these challenges that the Canadian medical system is facing. And hopefully we're going to highlight a few of those today. So to kick things off, we kind of wanted to get a pulse check on things. So let's update those figures from that 2017 report and really see where physician assistants are in Canada and some of the challenges that they're facing. So currently there's about 902 physician assistants working across Canada. That's both civilian and military PAs. If we look at that civilian PA population, they're currently working in 6 provinces: Manitoba, New Brunswick, Nova Scotia, Alberta, Ontario, and Saskatchewan. Now, as Christy pointed out in the presentation, there have been a crazy evolution in this field within the last 6 months or so. We've even found it challenging updating this report on a constant basis to make sure we included all the provincial legislation and policies that were kind of evolving over, like I said, the duration of the publication of this report. So obviously this has expanded to this point. And I also did want to note that within the report too, we do go into each province's funding. We go to their average salary ranges, and we talk about some of the policy challenges that they're facing. We didn't go over that in depth for this presentation because we wanted to focus more on that modeling perspective, but that is contained in the report if you guys would like to see it. So one thing that we really can take a step back and look at is that what are some of the issues facing this continued integration into the current provinces that are hiring PAs or the ones that have not up to PAs yet. So what we found is that there's number one, a lack of role integration, and number two, there's that standardized funding opportunities. Okay, so the lack of standardized funding opportunities. Now, what we've seen in the literature and what we've heard from PAs is that there's provincial funding opportunities that are currently out there are very variable and they're limited. Not to say that there's an issue across the board. There obviously are some very successful funding opportunities for physicians in select locations, but on a whole, this is something that we did find and we have heard from PAs. The last two components are really surrounding that accommodation piece. So we have a lack of accommodation as part of a provincial college of physicians and surgeons. We also have a lack of accommodation as a regulated healthcare professional. And what this is kind of what this is mounted to is number one, short-term contracts for PAs. This has created lack of job security, as well as a reduced opportunity for integrated practice presence across the nation. Now that we knew where PAs were, we knew some of the issues they were facing, we really wanted to take a step back and say, how can PAs enhance medical practice across Canada? So what we did is looked at this micro perspective and kind of tried to take a step back and say, let's look at this as a macro perspective. What are the main issues facing practice efficiency on a whole? So that whether that be in orthopedic surgery, whether that be in primary care, whether that be in emerge, okay? And 5 of the pillars that we really found from this was that 5 of the ways that you can increase practice efficiency in these practice areas are going to be by obviously increased practice efficiency in general, by increasing patient care capacity, increasing job satisfaction, decreasing physician burnout, and increasing patient satisfaction. But how do you achieve those? So what we found is we kind of dug into this a little bit deeper through our literature and environmental scan. And what we've really found is that the team-based model of care could potentially be a solution for all of these. So first and foremost, what is team-based care and how do you achieve it? All right. So first and foremost, to achieve team-based care, you need everybody to be on the same page. Okay. So you need people within a practice to promote to obviously promote team-based care approach and expand this team-based model of care and funding within their organization or practice setting. And what this could do is that it basically reassigns the task to designated healthcare professionals within a team and basically puts people within their scope of practice to make a well-oiled machine, whether that be a physician assistant, a nurse practitioner, or medical assistant, just to name a few. Basically, it gives people onus over their responsibilities within their scope of practice, and it makes things run a little bit smoother. Once we have this, what it's shown to do is have enhanced team collaboration to prioritize workflow. We've been seeing improved access to care and services, as well as potential to increase the number of patients seen through this increase in efficiency. Now, how does the PA kind of fit into this? So there's been a lot of literature supporting the fact that newly PAs can increase the scope of generalist services provided within a practice. But we didn't want to just end it there. So we know that PAs are capable of a lot more than just general service provided. So what we really wanted to focus on and what we think that this team-based approach can really do is that as PAs increase in experience and they increase in that relationship with their supervisory physician, we have that opportunity to go into the more complex patient cohort and basically increase the practice efficiency overall through role sharing with the physician. The other thing we found, and this is kind of the elephant in the room, we do like to mention it. One of the pieces that we did find through our literature search was that PAs were noted to be utilized for medical scribes and administrative tasks in a lot of healthcare settings. And there was justification in some of the data to say that PAs could be utilized for these central roles. In our opinion, and the opinion that has been reflected in the report, our vision for PAs is much greater than that, and it's much greater towards the patient-facing role. Okay, I think at the end of the day, a couple things that we really need to note here is, first of all, medical scribes are much better suited for that scribe role. Okay, they have a specific training that's going to be very different from the scope of practice of the PA. Okay, and in addition to that, I think something we need to address is that administrative task duty. Okay. PAs are not meant to just focus on administrative tasks. Rather, when we talk about that role sharing, what we find is that physicians and PAs are much better able to manage the patient caseload and the administrative duties done, and kind of pass off and utilize each other for their strength to increase that efficiency portion. So one person picking up the loose ends at one period of time, and the PA or the physician picking up loose ends at the other period of time, again, to create a much better oiled machine and a much more efficient practice moving forward. So overall, a result of our literature search is that we really found out that PAs have a large impact potential, or can have a large impact potential to the Canadian medical system. And if we look at this from a macro perspective, we can find that patients, first and foremost, are at the forefront of the impact potential for introducing PAs. Okay, we know that there's a number of direct and indirect benefits for further PA integration. And there's a lot of value-based transformations to the healthcare system as a result of introducing a PA through reduction in wait times, improved management and continuity of patient care, improved physicians' quality of life, as well as positive contributions to productivity. So a good example of that is going to be the increase in number of services provided. And really, all of this is hypothetical until you really kind of map it on to the dollar and cents, that economic and clinical modeling. And this is really what the next steps were in our journey. All right. So the first things first, we need to create a model, okay? So for any of you people who are very interested in quantitative data analysis, or economic data analysis, this is where we're kind of going to get into the meat of this. And I ask that it is heavy at times, and I hope that we can simplify it for you guys. And we've tried to kind of go through step by step, but I think it's really important to display to you guys how we came to our results, and it'll let you understand those charts and figures that are in our report a little bit easier. So this is the overall structure of our model. So the first thing we needed to do was basically figure out our two modeling streams. All right, so for our purposes, we looked at the payer structure first. All right, so where would these funds be coming from to actually pay the PA salary? So on the left-hand side, we see a public funding model. So this would be where the government would be paying directly to the PA through whether that be procedure codes, etc. Okay. The next area we wanted to look at was that employer remunerated funding model. All right. So that's where PA services are going to be are going to be paid through either physicians, physician groups, individual practices, or allocated funding sources that are not directly from government spending. Okay. One thing you will see in some of our charts is that we have referred to this in some context as a private payer model. Okay. We're not referencing at all the patient paying any fees or anything like this. It's always going to be employer remunerated funding, but it's just different than our public funding model. All right. The next component of this model that we needed to look at was basically, how do we separate the actual service provision of this? So we need to obviously model a status quo versus our intervention model. Okay, so basically our control model for this is going to be that reference model where it's the physician only. It's going to reflect the physician services and the physician fees provided as a status quo, as if you were to look at the data for current Canadian practice. And then basically what we did is that we took an intervention model and incorporated a PA, whether that be through service provision, the number, the time that they were able to provide services, and basically the cost savings to the system. And this brings us to a little bit more of an in-depth explanation of how we did this. So if we look at each of these variables, we included 5 pillars that were going to be included metrics, or we called them resources for this model. So the areas that we included in this were first and foremost the number of services provided. Okay, so that's going to be the number of healthcare services provided in Canada for fiscal year 2020 to 2021. We'll describe a little bit later why we chose those years in that data set. The other component that we wanted to include was obviously the mean physician cost per service. Okay, so we obviously needed to see the cost per services provided in Canada for fiscal year 2020 to 2021, and that was averaged across all provinces and territories that were included in this data set. The next thing we needed to include was the actual PA cost per service. So what we did with this was calculated as a discounted physician cost per service. So basically we took that mean physician cost per service and discounted it a certain percent. And like I said, we'll explain a little bit later on what those percentages were per practice area. The next area we wanted to talk about was the mean duration per service. Okay, so we needed to kind of attribute or include a time variable for this. So we needed to know how long a PA was spending on one of the services that they could provide, so that we knew how many hours or minutes they were able to kind of displace the physician time of practice. The last thing we needed to know was the mean proportion of PA involvement in service. So this is the percentage of time that a PA delivers a specific service, okay? A good example of this, and this is variable by practice area, and I can kind of give you an example of two separate scenarios. In primary care, the PA is a lot more autonomous. They're typically seeing patients on their own, and there's limited physician involvement, okay? So that would be more of 100% ability for the physician or for the PA to involve themselves in that service. If we look at something like orthopedic surgery and something such as let's do patient follow-up or something like this, they might be performing that service 85% of the time, with the other 15% of the time being the orthopedic surgeon. So again, these are where these percentages change, and this will obviously play into how often and how many hours the PAs are actually able to save the system and the physician. Before we jump into the next model stage, we kind of wanted to express a couple of assumptions that we did make across the board for all of the models. Okay, so first and foremost, all of these models are based on a fee-for-service method, okay? So the reason why we did this is we looked at the discounted fee-for-service model used in the United States. An example of this is going to be the 85% of the physician fee schedule for Medicare reimbursement. But the one thing we didn't incorporate is that incident to billing. So that was the ability for the physician to bill for the remaining percent of that discounted billing. So for instance, it was 85%. The physician would bill for the remaining 15% if they were involved in the service, and therefore there'd be no savings to the overall healthcare system. Therefore, we did not include this incident to billing, as it wasn't reflective of something that we were potentially going to be incorporating. The last portion we wanted to discuss was that discounted fee for service. One of the things we did was play with that discounted fee for service to basically be reflective of the current average of PA salaries. And that's going to change, obviously, by practice area. You're going to see that a little bit later. But we think that we've done a really good job of actually reflecting the average current PA salary, giving that range of PA salaries that is reflective of current salaries that are across Canada right now, and even potentially showing the ability to increase PA salaries in some instances. The last thing we wanted to discuss as an assumption, was that PA regulation structure. So as per Canadian policy, all models are going to assume that PAs are supervised from an attending physician, okay? The level of physician supervision varies obviously by practice setting, PA experience, and obviously the physician and PA professional relationship, all right? This is something we're going to discuss a little bit later on, especially when it comes into that incorporation, that team-based model of care. Last thing is we have not included any non-covered elective services, okay? So we do understand, and this was through interviews with PAs, that they do have the opportunity at times to perform non-covered elective services for additional income. We've not included that as an additional component to this model. Okay, and here comes the fun stuff. So hopefully this is all clear as mud. All of the models are going to be represented very similarly. The only difference is for the primary care model, we're going to go into a little bit more detail. It's going to be reflective of exactly how the data is set up in our report. So it's going to help you guys, give you guys a little bit better understanding of how we arrived at each of our numbers and each of our results. And then we'll kind of summarize the emergency medicine and the orthopedic surgery ones in a little bit of a condensed fashion. So First and foremost, we need to kind of set up 4 pillars before we jump into each of these models. So if we the first one is the total cost of primary care services in 2021, and that amounted to about $6.7 billion per year. All right. The next component we wanted to look at was the total number of time that a physician was spending on services that were within a PA scope of practice. So where could that PA be inserted to actually save the physician time? So what we found was that physicians in primary care were spending about 28 million hours per year across Canada doing services that PAs could provide. All right. The next thing we needed to do was figure out how many hours a week a primary care PA was working. We did this through both key informant interviews as well as any available data that we were actually able to source from this. And what we came up with was that PAs were working an average of 37.5 hours a week in primary care. And what this amounts to is a total potential savings of about 2.1 million hours per year in the primary care setting, which amounts to about a 7.3% savings in time for physicians. So this is going to summarize and give you a little bit broader or a macro view of what those time savings will look like. So first and foremost, I think it's important to identify that to achieve those time savings of those about 2.1 million hours per year, it would take about 1,145 physician assistants being injected into the system to create both the time and that cost savings per year. Now, I think we can all understand that this is not going to be happening overnight. So what we've done here is included a reduced percentage to kind of reflect what the actual offset of cost savings per year and time savings per year would look like if we were to inject this certain amount of PAs into the system. For our modeling perspective, we used that 100% injection into the system. And there's a couple reasons for that. But the primary area, what we were really interested in is that if we look forward into the future, and especially if we look at the number of PAs practicing per year, I think we looked at the number of primary care docs, and it was something like 48 to 55,000. I can't remember the exact figure, but I don't think it's unreasonable to say that in the next 10 years, this could be a potential number that we could reach. So I think, in all honesty, if we're looking at our models, this is the impact potential that we're looking to describe here. But obviously, if we wanted to, for future modeling circumstances, we could reduce the number of PAs for a specific setting and actually look at that, both clinical and economic impact. So now that brings us to our analysis and model comparison. So this is going to be these are going to be the charts that you're going to see outlined in the report, and I'm going to walk through them one by one. The biggest thing I want to notify you of at this point is that we've done 2 scenario analysis for each of the practice settings, okay? So you'll see at the top of my screen, it'll say scenario analysis 1 or it'll say scenario analysis 2, all right? The difference between the two is as follows. Scenario analysis 1, as you'll see under practice efficiency increased in physician time, you'll see that figure of 7.3%. Okay, so that's what you saw on that first slide. Basically, that's the metric of the amount of time that physician assistants can save physicians. All right. The scenario analysis 1 is going to assume that that amount of time savings is injected completely back into work. All right. So you're going to assume that that is completely back into practice, and it's obviously going to increase the number of services and going to increase the cost to the public system. Scenario-based analysis 2 is going to assume that there's a split in proportion between increase in physician work-related time and that the physicians are obviously going to likely in some circumstances going to take some of that time and put it towards non-work related activities. And this is what we had, we'd gotten this feedback from many individuals from the RAB to interested stakeholders in this project. So these are the 2 scenarios, and we're going to walk you through each one. And we think it gives a good representation of kind of a split of what would likely be the scenario if we were moving forward. So the first area we wanted to describe in this model, so this is scenario-based analysis 1, is that control model, okay? So you'll notice in that top line, you'll see there's a control model and 2 experimental models, all right? We did omit model C for this because it's exactly the same as model A, all right? So it's just, they're both control models. So what you're gonna see is first and foremost, we have that physician service provision cost to the public system. So you would have seen that in the previous slide. That's at $6.7 billion, the status quo, what is currently represented in the medical system. We have zero increase in physician time, okay, because we don't have any PAs integrated into this model. And it ends up in about 52 million services per year. And we have a total cost to the public payer of that 6.7 million with no savings or cost to the public system and no additional costs or saving to the private or employer remunerated payer. The next area we want to look at was our first experimental public funding model. Okay, so first things first, we have a reduced cost to baseline physician service provision. Okay, so we have $6.5 million in physician service provision. The reason why that's reduced from that 6.7 million is obviously because we have that introduction of the PAs and at that reduced cost per service. Now, if you look at the second line, we see that additional $175 million due to increased service provision. So if we put physicians are putting that 7.3% of time they're saving back into practice, it effectively would reach that $6.7 billion again. The only difference this time is we have that additional cost to the public payer of that $131 million per year. As we move down, the number of services provided go up by approximately 4 million services per year. However, what we end up with is an actual net cost, net additional cost to the public health system of about $131 million per year, mainly for that physician assistant salary. The next model we're looking to explore is that employer remunerated model. Okay, so again, we have that baseline service provision of about $6.5 billion per year. We have that increase in physician service provision from that 7.3% increase, which is an extra $175 million per year. The only difference is now we have that cost to the independent employer of about $131 million per year to cover for those physician assistant services. And what we find there is overall, we actually have a net savings to the public healthcare system of about $17,000 per year. We end up with that same approximately 4 million additional service provided, and we actually end up with that additional earning potential to the private independent employer of about $43 million per year. And now is where things get a little bit more interesting and a little bit more fun to play with. So exactly the same as the last model. The only thing we're changing now is that practice efficiency component, okay? So we're looking at the fact that physicians are only going to increase their work-related time 5.5%, and they're actually going to use that 1.8% of the time to put into non-work-related activities. So as we saw in the beginning, one of the key components to that practice efficiency piece across Canada that we had found in a literature review was that physician burnout component, okay? Not only that, there's a lot of other metrics surrounding what this physician time could be used for. It might be used to more exposure, more time with the patient. It might be used for professional development. It might mean that, maybe just the physician and the PA can get home on time instead of having to spend an extra hour in practice, okay? Whatever it means, we have not made assumptions on this, but we've included it as a component there because, as we saw earlier, it was a key component to increase or enhance practice efficiency. So if we look at 5.5% of the time put back into the workload instead of that 7.3, we still see approximately 3 million, an additional 3 million services provided. However, we still see that main cost to the healthcare system of about $88 million. If we switch gears to the employer remunerated funding model, we still get that increase in 3 million services. However, at a tremendous cost savings to the healthcare system of about $43 million and about a cost neutral approach to that independent payer model. So one thing that we did want to note and that we did include in this model was that we tried to achieve a cost neutral approach to this. So what would it look like for the independent employer to hire the PA, be able to put time back in their pocket, as well as basically cover the PA's salary? As a result of these models, what we found is that for primary care, we looked at a discounted fee for service between 75 and 80%, okay? For all of the models you see and all of the models you're going to see moving forward, we used a discounted fee for service of the baseline discounted percentage. Reason being is we were looking to reflect the integration of a newly hired or newly graduated PA. Okay, so what that basically amounts to is a salary of about $114,000 per year for the PA, all the way up to, in that range, to about $122,000 per year for that 80% discounted fee for service. So the next area we're going to look at is emergency medicine. So like I said before, we do have emergency medicine, we have orthopedic surgery. So I've kind of created a little bit more of a streamlined approach for these. I haven't gone as much into detail about each of the models. So we'll hopefully run through these next two sections a little bit more effectively. So as you saw before, these are the four pillars or the four variables we need to start with for each of our models. So the total cost of emergency medical services in 2021 was about $5.67 billion. Total time a physician was spending within the total time a physician was spending on services within a PA scope of practice was about 4 million hours. And the average PA working hours were about 9.2 hours per shift at about 16 shifts per month. And what this amounted to was about a 3.2 million hour saving. And what that amounted to was about 80.1% of the time of the physician of the time that physicians were spending on practices or on services within a PA scope of practice. To create that 3.2 million hour savings and that $431 million cost savings, it would take about 1,813 emergency medicine PAs to be injected into the system. And we can kind of look down the list there and see what the reduction in the number of PAs and the influence they could have on the public, on the healthcare system savings as well. So the first thing we wanted to talk about is that scenario one analysis. So again, if we want for this purposes, we're focusing on that 80.1% of the practice increase in practice efficiency put exactly back into work. Okay, so these emergency medicine docs are having this time savings and they're going to use that to put back into practice. Okay, so what we see here is, if we're looking at the experimental model from a public payer perspective, all right, we have an increased service provision by over 10 million services, okay? But we have that huge cost to the medical system or the healthcare system of almost $200 million. If we swap and look at our employer remunerated funding model, we still end up with that over 10 million increase in services provided. However, we end up with a net savings to the healthcare system of about $18 million and actually an increased earning potential of about $413 million for the independent employer. For scenario analysis two, we've decreased the percentage that the independent employer or the physician is going to be putting it back into practice by about 52%. So they're only putting 20.8% of their time savings back into practice in this scenario, okay? And for those purposes, we're still looking at over 4 million services increased, okay? And even with this amount of service increase, we're actually seeing a savings to the public healthcare system by about $211 million. If we swap to the employer remunerated perspective, we still get those 4 million increase in service provision. However, our savings has effectively doubled to about $426 million for the public healthcare system. And again, we have $4.7 million increase in earning potential, which effectively would equal a cost neutral approach to hiring the PA under this funding model. In all, for this specific practice setting, we're looking at about a 30 to 5% discounted fee for service. For our purpose, we used that 30% discounted fee for service, which effectively ended in a $102,000 salary per year, all the way up into earning potential, that 45% discount fee for service, which would reflect about $155,000 per year. Last but not least, and hopefully everybody's bearing with me, this is the last one, is going to be the orthopedic surgery model, okay? So total cost for orthopedic surgery services in 2021 was $597 million. Total time of the services within a PA scope of practice, about 101.7 million hours. And the average PA working hours in this practice area was about 7.92 hours per shift at about 4.1 days per week, which basically effectively resulted in about 717,000 hours in total time savings, which is about 40.8% of that 1.7 million hours, which is that time that physicians were spending on services within a PA's scope of practice. The number of PAs required to make that time and cost savings was about 423. And what that basically amounted to is about $115 million a year in cost savings. For a model comparison, that scenario one based analysis, where we're assuming that 40.8% of time savings is going to go directly back into practice, what we see here is an increase in service by over 1 million services per year, with when we're discussing orthopedic surgery is extremely substantial. And we do see actually cost savings to the public healthcare system of about $1.5 million per year. Okay. On the flip end, if we look at the employer remunerated funding model, we still see that over 1 million service increase in service provision. However, at a cost savings to the public system of about $59 million per year, and an additional earning potential of about $56 million per year for that independent employer. For our scenario-based analysis 2, we obviously took some of that time back to utilized some of that time back into non-work related tasks, and we used a figure of about 21% of their time back into practice. What that amounted to was about 3.9 million services per year. Okay, so right around that 700 increase in about 700,000 increase in service per year, with a savings to the healthcare system of about $57 million. If we look at our experimental model for employer remunerated funding, we get the exact same increase in service provision. However, at that savings of $115 million per year to the healthcare system, and again, approximately a net zero cost or savings or earning potential for that independent employer. For orthopedic surgery, it was very similar to emergency medicine, where we saw about a 30 to 45% discounted fee for service. For our purposes in our model, we used that 30% fee for 30% discounted fee for service. Salary range for orthopedic surgery ranged between $117,000 to $156,000 per year. All right, now we can all take a very deep breath. That was those are the main and central components to the model. But now we get to kind of go through the what I would consider the fun stuff and kind of translating what this means for our PAs. What does this mean for our healthcare system and our patient population in general? So first and foremost, we've broken down our impact into 5 pillars. Okay, so by integrating physician assistants, we have an opportunity or the potential for decreased cost to the public healthcare system. We have the potential for decreased wait times, potential for increased number of services, potential for increased physician time, as well as the potential for increased access to primary care. And I'm going to go into each one of these a little bit more in detail. So first and foremost, okay, we have the decreased cost of the public healthcare system. And I think that was very clear across most of the models that we've basically highlighted today. So if we looked at all the employer remunerated funding models, we saw an overall net savings to the healthcare system. And in some instances, when we were talking about emergency medicine, we saw a potential savings to the healthcare system of almost $426 million, which is massive. All right. The other thing we need to consider here is the potential for the indirect cost savings as a result of this decreased cost to the public healthcare system. Okay, so by introducing these PAs, we might have the greater continuity and access to care. And for all of our public health and epidemiologist connoisseurs out there, we have the opportunity for increased disease prevention, which is obviously in a long run kind of taking that upstream approach, and obviously can have that indirect cost savings to our public healthcare system. If we want to talk about decreased wait times, this is very important, okay? So if you look at emergency medicine over the last 3 or 4 years, especially during COVID, what we've seen is that wait times have exponentially increased since 2021. Actually, in some circumstances, the lack of staff and other factors actually forced emergency departments to close, and they've never experienced levels of patients like they have before, especially in rural and remote communities where we've actually seen some emergency rooms shutting down for over 530 hours in a 6-month period. So that's a tremendous impact, especially for a practice area that we've included as part of this model. The next portion we want to talk about decreased wait times is that orthopedic surgery component, okay? So what we found was that about 62% of patients received their joint replacement within that 182 standardized day frame in the Canadian medical system. So if we bunch these both together, we can obviously see that the impact of this decreased wait times could have just on these two practice settings, let alone if PAs were integrated into additional practice settings themselves. The next area we want to discuss is that increased number of service provision. Okay, so what we saw from our modeling was we saw over 7.6 million additional services being able to be provided through that employer remunerated funding model. What this could amount to is a decreased backlog for appointment procedures, as well as impact that potentially that dangerous burnout kind of that burnout perspective that we've been kind of dealing with across our healthcare system through a number of healthcare professionals. The next thing we want to talk about, and this has come up several times, I find that this component can sometimes get confused as we're trying to, give physicians back time so they can kind of leave work and dump it on the PA. And it's not really what we're trying to go for this component. As you saw when we chatted about the pillars of practice efficiency, one of the biggest things we saw was that, number one, physicians are not able to spend enough patient-facing time. Okay, it's a very quick in and out. And what we're seeing is that physicians are not able to have a lot of non-patient or non-work related time as well, which is obviously leading to burnout. The OMA released a report that stated that about 1 in 2 physicians and residents reported high levels of burnout, and this obviously compounded by the recent pandemic. But there's room now for that professional development side, the personal side, and that increased physician time is just going to enhance and give the patients a much better experience. And again, it's not that we're looking to have the physician leave early. We're looking to enhance that practice and especially impact that team-based model of care where the PA and the physician and the healthcare staff in general for most practice settings are able to leave on time due to this increased practice efficiency while also increasing the number of patients and service seen and the services provided. The last component that we really wanted to look into was that increased access to primary care. Okay, so as of 2019, Statistics Canada posted that about 14.5% of Canadians over 12 years old did not have a family doctor. And this is expected to grow in trajectory to about 20% in the next 5 years. So by incorporating PAs in family practice, what we can see is through that increase in service provision, we actually might have the opportunity to increase that patient roster. And this is tremendously advantageous for health teams that could have potential for specific bonuses or premiums for community-centered primary care teams as well. So we've gone over our model, we've gone over our impact potential and what these results could kind of translate and how these could translate into practice. But I think something we want to kind of leave you as a take home is obviously our recommendation and the recommendation that we made in our report. So if you look back, there was obviously 2 scenarios that we were looking towards. The scenario 1, which is putting complete time savings back into practice. But we wanted to find that hybridized model where we could actually really take in that increased physician time component. Okay, so from our experience, given the metrics that we've kind of found here, our recommendation would be that scenario 2 employer-based PA funding model. Okay, and we're going to discuss both the direct and indirect benefits of that model. So first and foremost, okay, there's obviously the healthcare system savings, all right? Across all practice settings, primary care, emergency medicine, orthopedic surgery, we saw complete savings of about $585 million to the healthcare system. At that amount of time back into practice, we saw increased service provision by over 76 million services per year, all right? And last but not least, we had that increase in physician time for both work and non-work related activities, which was about 1.8% for primary care. I understand this is a little bit low, and we're going to discuss that a little bit later on. We saw a 52% increase for emergency medicine doctors and a 19.8% increase for the orthopedic surgeons. All right. In addition to this, we feel that this has a lot of indirect benefits. If you remember what we discussed before, first and foremost, there was that team-based approach, okay? It was unanimous amongst the individuals that we spoke for through the key informant interviews and just general conversation when we were undergoing this project that of the importance of that supervisory relationship between the PA and the physician, okay? When that relationship grows and when there's incentive to grow that relationship, all we get is that increase in practice efficiency, okay? So we feel that if the employer is motivated to enhance the practice and enhance the relationship to that PA, All that's going to come out of that is obviously increased experience, increased autonomy, and a much more well-oiled machine like we were discussing in that team-based model approach. The last area we're going to chat about is model limitations. And I think that these are really important perspectives, especially when we talk about the next steps that we're looking to be taking after this project. So as mentioned before, when we were discussing the importance of the RAB, one thing that we noticed throughout the duration of this project was that overall there was a lack of PA data, okay? We found several PAs themselves who are launching services or surveys within their individual practice areas or practice settings. But overall, amongst all the literature, Canadian literature especially, there's a lack of PA Canadian research, okay? So our recommendation here is that we need increased quantitative data, specifically practice setting and workplace characteristics, where PAs can basically, where we can kind of mark PA's impact clinically. The other thing we need to know is we need clear role identification in healthcare system databases, and this would make it a lot easier to say, okay, this is the amount of time the PA was spending on individual service provision, et cetera, so that we can more accurately get these figures instead of using estimates. So although we had this as a limitation for our project, like we said, we did have inclusion of expert review to inform our model. This was especially true for the number of hours that PAs were spending and the proportion of time they were spending on practice. However, like I said before, we feel like it would be a much stronger model if we were able to actually get increased data collection on this subject and able to apply this to our model. The next thing we wanted to talk about is our primary care data and our primary care setting of interest. So out of all the practice areas, primary care was actually the most void of PA data, okay? And what we found is that when we looked across the country, the most available data, and especially available data to us, was that Ontario-based family health team data. So for our purposes, we were able to utilize this Ontario-based family healthcare teams to look at the impact, both clinical and economic impact of these PAs within that practice setting, okay? So while this might seem kind of narrow-minded, we think that it actually does add a few strengths to our model. First and foremost, it incorporated that team-based model of care that we've been discussing, okay? And the next thing we want to discuss is that although not every province is obviously going this direction, the trajectory of many of the provincial primary care models is actually to adopt this kind of community healthcare setting. So there is transferability to some of these provinces, but obviously it's not going to be universal, okay? The other thing we needed to kind of discuss in that time frame is that PAs in primary care, it's a very difficult kind of niche environment. And one of the things we found difficult was if you're looking at, let's say we have a community healthcare team of, let's say 5 doctors, 2 PAs, and a number of other allied healthcare professionals, administrative staff. Obviously, the number of PAs in that practice is going to adjust the number of services they can provide, okay? So this is why for our individual conversation for this, the PA model might not be perfect, and this is likely why we only saw that 7.3% increase, especially when we're looking to apply the model. So for instance, if we look at emergency medicine, we're able to have the PA take on certain services that the physician was utilizing before, and the physician can spend time on different services. In primary care, what we found is that there's a lot more parallel work environments, okay? So the PA can perform many of the services that the physician can perform as well, right? Because they're working in parallel. This is especially true when we were discussing many of the rural primary care health models where the physician actually would rather 2 or 3 PAs sometimes to the one physician because they were unable to recruit physicians for that exact practice setting. So in that circumstance, obviously the number of PAs would impact and increase the number of services provided, and that percentage would obviously be offset. So that is kind of something we did want to note for this specific study, and likely a really important next step on actually looking into the exact impact that PAs can make in primary care in specific settings. The next thing we wanted to chat about was the data set selection, okay? So as you saw in most of our models, we use that 2020 to 2021 healthcare utilization data from CAPA. The reason why we did that was, number one, it's the most recent, it's the most complete, and it was publicly available. Okay, so this is why we used this data. When we looked forward to that 2021, 2022, we actually lost some of the provincial data for some of the practice service provision. So for that reason, we backed up. Now, what this does is it raises the question of the impact of that COVID-19 on this data set itself. So what we actually saw was our data set. We compared to pre-pandemic and post-pandemic, just looking at any of the changes. And what we actually saw was that our model for compared to pre-pandemic rates was about 5.8 to 11.1% lower than the previous years. So what that tells us is that we're actually underestimating the potential impact that PAs could actually be having in a lot of these practice settings. The last thing we want to discuss, and this is the last limitation I wanted to kind of outline, is that pan-Canadian data set we were just discussing. So that CAPA National Physician Database data. So if you look, one of the challenges of looking at national data is that there's variation in provincial service codes. And what that results in is basically combined service categories. Okay. So for our circumstances, what this meant was that primary care and emergency medicine were actually bunched together. So we basically went through and isolated the services that would have been for primary care and the services that would have been for emergency medicine. So we separated the data set first and foremost from that. But what happened was that obviously the data that had been collected averaged the cost per service. So what we likely saw was an overestimation for the costs for primary care and likely an underestimation for the cost for emergency medicine, as we see that emergency is typically a little bit more expensive cost per service and primary care is slightly lower. Okay. But like I said, since we had this underestimation, this would likely come out in the wash. But we did kind of want to make note of this. Last but not least, there is a lack of select provincial and territorial data. So Yukon, North South Territories, and Nunavut do not provide data for CAPA, and as well as the province of Quebec. So it is important to note that obviously we would like the territorial perspective on a lot of this moving forward. The other thing is obviously Quebec is home to major city centers, which would obviously impact this data. So again, moving forward, this would be something that would obviously strengthen our model. All right. Now, last but not least, we just want to talk about future direction. Okay. So if we wanted to use all the information we have to move forward, what do we think is the most successful path that we can carve? So first and foremost, we recognize the fee-for-service model is utilized broadly across Canada. However, in some practice settings, especially in emergency medicine, we see these utilization of alternative funding agreements. Okay. So one thing we need to do is basically future models will obviously need to account for individual province billing and in the service provision. And number two, it's going to obviously need to account for whatever that specific practice setting remuneration strategy or model is. Okay. The other thing we wanted to do is, like I said, kind of narrow down to a specific care setting in the province. Okay. So a good example of this is highlighting the actual full impact of PAs in primary care in a province like Ontario. Okay. So look into it a little bit more in depth into that primary care setting. Look at the actual impact and the number of patients and the time PAs are spending with patients in each of these practice settings, and really get a firm model that would say, by integrating one PA into your medical practice, this is the potential clinical and economic impact. Okay. The last things we wanted to do, kind of note here, is that out of all of these results, I think that we can all agree that there's a tremendous potential and opportunity for further PA integration. Like Christy said at the beginning of this presentation, the remaining provinces are slowly uptaking the idea of integrating PAs. However small that might be, we think it's a giant step forward for realizing the full potential and really kind of addressing that healthcare crisis that we had noted earlier on. So if you guys, we would invite you all to, before we wrap up, to when you have an opportunity to read the report. So the Unlocking Potential report is on the Conference Board website. If you go to our health page, it's right on the front page there as soon as you click on it. And finally, thank you for everyone. Thank you for all the contributors, the funders for this project. And we're really looking forward to taking the next steps with this and seeing where it leads us in the world of PA integration across Canada. Thank you, guys.
Thanks so much, Chris. That was very informative. I hope everybody here that has joined us also found it insightful. And if there are any questions, please let us know. The floor is open to you. Not seeing anything in the chat. You're welcome to unmute yourself if you would like to speak as well. Okay, we do have Seth. Please go ahead.
Thanks very much for your presentation. It was insightful. I am a PA in hospital. I do inpatient medicine, but I do cover the medicine component of the orthopedic surgeries. So I appreciate that. I had a question though, as it relates to the primary care setting. Was there any thought to, the 20-ish% that has no family doctor, especially if you're thinking about, in Ontario, that number might actually be higher in certain rural areas. They go to emergency rooms, they go to walk-in clinics, and those are expensive visits as opposed to what the cost per visit for a primary care visit for per se.
Yes.
Was that factored into the cost savings if you shift those patients to family practices now that they can do that with a PA? I know that practice is closely paralleled, but I didn't fully understand if that had been kind of played out in the data, because if you were to incorporate that, you would have an increased patient roster for that physician. He would have an increased remuneration from the billable hours, but also you would have a drop in efficiency, sorry, an improvement in efficiency and a drop in price to the healthcare system writ large. But I didn't know if that was fully kind of put in there. And that's just a thought. I mean, obviously it's not studied, but I was just thinking that might be an obvious place that could boost could boost the argument for primary care PAs.
Yes, yeah, and thank you, Seth, for the comment. So we agree with you 100%. So one thing, obviously, we weren't able to model that because it's very difficult to estimate the figures and the statistics on that. So really where that component came into play is if you see in my point here about decreased cost to the public healthcare system, that's where we mentioned and discussing the indirect cost savings. So that greater continuity and access to care. So people are able to seek primary care appointments instead of having to go to emergency medicine. They're able to, obviously, we're able to influence that disease prevention component as well by potentially increasing that access to primary care. So it was more of a discussion piece and obviously a savings potential that is going to be further discussed. But for our circumstance, we didn't have the figures to model against it.
Thank you.
Thanks, Seth.
Are there any other questions? So this has been recorded, and we will be sure to make the recording available as well. Chris, if you'd be comfortable sharing the slides if anybody's interested. And yeah, we thank you for your time. If you are interested in having a one-on-one meeting, we're also available to do that if you would like us to present to other members of your team or whatnot. So feel free to reach out and I would be happy to arrange that. So thank you all for joining us. And yeah, we're here to help. If you have any questions, please feel free to reach out. Enjoy the rest of your afternoon.
Thank you, everyone.
Oh, Seth, one more question.
Oh, I think it's a wave. I don't know.
I was just
it's a wave. Okay. Take care.
Thank you, Christy.
Thank you, Chris.